Professor Brendan Murphy, Chief Medical Officer of Australia, described as the public face of Australia's fight against COVID-19 and surely one of the busiest people in the country. Welcome.
Thank you, Penny.
So, Brendan, in your role as Chief Medical Officer, you are seen as the face of the COVID-19 response, and rarely has a medical practitioner been in a position where their advice has impacted the lives of millions. What's it been like for you to shoulder this responsibility?
Thanks, Penny. Well, it has been an enormous responsibility, although I do need to say that it's a collective responsibility of the Australian Health Protection Principal Committee, which consists of all of the state and territory chief health officers and a range of experts that we've co-opted. And one of the really positive things about this pandemic has been the collective consensus views of the experts, because this pandemic doesn't have a rule book. We really are every country is finding its way, and the decisions we make have impacted the lives of so many Australians, or the recommendations to governments who actually fundamentally make the decisions have been quite momentous. And so it's been very, very reassuring to have that collective view of the group. Now, certainly I have had to then sell to the National Cabinet or to the Commonwealth Government some of those recommendations.
They're pretty tough decisions you've had to make about social restrictions. How have you managed to balance the health impact with that of the wider economic and social consequences?
Yes, and that was obviously a huge debate. I mean, I think one of the interesting reflections is that if you do have a large uncontrolled outbreak with lots of deaths and lots of impact on the health system, that's probably just as economically damaging as shutting down the economy by physical distancing. And it's interesting to reflect that a country like Sweden, that really hasn't practiced much in the way of restrictions, has had just the same economic downturn, if not more, as Australia. And in fact, Australia, whether it was by good decision-making or a bit of luck or a combination of the two, we've done pretty well. Our economic hit so far has been much less than a lot of other countries. And we often compare ourselves with New Zealand, who took a much more aggressive lockdown, and they've had a bigger economic hit. They're in a very good position. We think we're in a good position too. But there's as I said, there's no rule book, there's no right approach to this. You know, with pandemic influenza, which we had a well-developed plan for, which we used and adapted for the COVID-19 plan, there's clearly an end game. The end game is getting the vaccine. With COVID-19, we don't really know what the end game is. So our planning horizons are relatively short to medium term and continually being reevaluated.
So how have you managed to make evidence-based decisions in an environment where the evidence is moving so rapidly, changing, and at times sometimes we're getting evidence that has not always been peer-reviewed and there's occasionally a bit rushed?
Yes, I think that, and well, when we started with this pandemic, you know, we were almost relying on media reports. There wasn't much scientific evidence at all. And the first papers came out of Wuhan from Hubei province, and then, of course, a lot of stuff coming out of Italy and Europe and the US. I think it's true, there's so much rushed publication. We've contracted a Cochrane review group to look at evidence. We've got a National Health and Medical Research Council, auspiced group of experts that also do some evidence reviews for us, and the chief scientist has also got an evidence review group. So we've outsourced a fair bit of that stuff. And you're right, if you believe some of the stories that come out, you know, you could be changing policy 3 or 4 times a day. And so, you know, all the evidence about asymptomatic transmission, about evidence about some of the therapeutic interventions, all of the hype about candidate molecules for vaccines. So we have to, keep a steady course. And it was very early on in the pandemic when our case numbers were rapidly increasing. You know, I was being bombarded every day by experts and would-be experts who, some saying, shut down harder, quicker, and some saying don't shut down, some saying do this, do that, and we had to try and chart a middle course based on what we knew and a consensus view, and it was tricky.
Yeah, no, absolutely. And I was thinking about those sort of armchair epidemiologists, as you sort of referred to. I was just wondering what sort of strategies you use to deal with that.
I think, and obviously those strategies played out in the media. I used to do early on, before I had my wonderful team of deputy CMOs, I was doing sometimes 4 or 5 media slots a day. And I used to say, look, acknowledge that there is no clear evidence base upon which decisions are making, that HPPC looks at a range of evidence and, we understand the anxiety of some people who are pushing a certain view, but we have to sort of assess the collective body of evidence and make the best middle ground decision. And I think in the main, we have done pretty well in that space.
One of the things that I would have imagined is most difficult for you in this has been trying to deal with the fact that the doctors and the other medical experts weren't always totally aligned behind your decisions. I was just interested as to how you dealt with that.
Yeah, I think in the main we've had pretty good alignment with the position we've taken, but there's no doubt that a lot of our medical colleagues were absolutely terrified. They were seeing what was happening in Italy, particularly early on, then in the US, seeing, portable refrigerated vans as mortuaries, mass graves being dug, particularly anxious about healthcare worker infection and healthcare worker deaths. And some of them, obviously had contacts in those countries. In the main, we've had a very good collaborative relationship with all of the colleges and the peak groups. The AMA, I think, has played a really responsible middle ground view. And then we'd also stopped a lot of elective work. And so we had this unusual situation where we had hospitals that were half empty and intensive care units that were, only had a few people in them. And so that's why we had to sort of restart the health system as things happened. So I don't think anyone would wish it to be other than the way we've had it, but I think it's been an unusual experience for a lot of those wonderful doctors who, if we had such a tsunami, I think our intensive care system would have been one of the best to cope in the world. And again, really positive engagement with the Intensive Care Society. ANZEX took a lead role with us from the outset, and we did all our expansion planning, purchased additional ventilators, were realistic about what we could do. So some really excellent collaborations have come out of this.
So on a slightly different tack, your career has progressed a long way from being a nephrologist responsible for individual patients. What are the aspects of frontline medicine that you miss?
Oh, the patient interaction is the most important thing that I miss. Even that when I was my last job before the CMO was CEO of Austin Health in Melbourne, which I did for 11 years, but I always tried to go to an outpatient clinic once a month just to get that connection, and it would help me with credibility with the senior medical staff, and it also meant that I could use the electronic medical record and as a user and defend people's unwillingness to move into the electronic age. But no, obviously as CMO I haven't done any clinical medicine. I try and keep up with the literature and do CPD to keep myself, and this job exposes you to so much. I do inquiries into dust diseases and natural therapies and all sorts of things. So I'm picking up a lot of stuff, but I do miss the most rewarding thing in medicine for me is that patient contact, the seeing, particularly in nephrology, we'd see people, have dialysis and transplant patients that you'd see sometimes for, 10, 15 years, and that personal contact, seeing someone, recover from a condition, do well, the joy of a dialysis patient with a successful transplant, having their life restored. I miss that a lot. I love teaching medical students and physician trainees. For all of my clinical life, including when I was a hospital CEO, I used to try and do physician trainee tutorials and mock long cases, because secretly I did it because it was the best continuing education you could do. If you've got a bright young candidate that you're pretending to ask questions when you don't really know the answer, you learn a lot.
So on the flip side of that, what are the clinical skills what skills have you brought from your clinical life into the current role?
A very careful view of the evidence. We are so bombarded with evidence now, and so much of it is, as you said before, not properly peer reviewed. There are so many proliferated of journals that are of not very good quality. We've even had a very major journal publish a piece that was not very good quality. So that ability to be calm and not react to information before you've checked it. I think probably more from my leadership of a clinical unit and my leadership of a hospital was this ability to bring people together. I'm not a public health physician. I'm less well qualified to manage a public health outbreak than most of the members of the AHPPC, but where I think I bring something is the capacity to get a consensus view out of them and to bring out their wisdom. So clearly being able to, you've got to be very, very cynical sometimes about evidence that's come to you, and to try not to be frightened and emotional and overreact, because there were times when I was being bombarded by all sorts of inputs, and you just have to hold a steady course.
How do you think that the nature of everyday clinical practice will change as a result of COVID?
Yeah, I think it is interesting. I think one obvious practical change will be, I think telemedicine will continue in of one form or another. I mean, I think the video consultation is probably here to stay, and some form of telephone medicine. I think some of us are a bit worried about how we use telephone consultations. There are some quality and safety concerns about that, and there's potential for misuse, I think, by some people who might want to exploit it. But I think Minister Hunt's pretty keen to keep telemedicine going for both consulting specialists and GPs. One of the interesting byproducts of the physical distancing has been we have completely interrupted the flu season. We haven't seen much in the way of influenza. Now, it's too early to say. It may well come back as people relax their physical distancing, but it does show that some of these sort of basic hygiene and distancing measures that we've been talking about for years, the stay at home if you're unwell message that we've all ignored, including me, that these sort of behaviours may change the way we have flu seasons and winter illnesses. So I think I am worried about some of the people who didn't get their cancer screening tests, who may have had elective surgery delayed. We do have to, there was even data suggesting that the incidence of myocardial infarction and strokes was lower during, for some time. Now, they were probably still happening, but probably didn't present to hospital. So I think we have to make sure that fear that was there doesn't stop people seeking routine medical care. It would be a terrible thing if we had a higher morbidity and mortality from non-COVID related stuff than we've had from COVID.
Absolutely. You can feel that fear as patients are still reluctant to come back into our rooms. So what do you think, in what ways do you think medicine might end up being better for doctors and for their patients as a result of all of this?
I think there might well be, people might reflect on when when a face-to-face consultation is needed, when a checkup, it may lead to some of that more holistic. If we do, for example, move to some sort of voluntary enrolment system with doctors, GPs, and their patients having some more of a less episodic and more holistic continuum of care approach. As I said, I think people might reflect on some of those things that they did that perhaps were wasteful, and I think it might have exposed things that we did that we didn't even realise were the case. I think there's also we've now electronic prescriptions are now going to be a thing of people. We won't be dragging people in just to get a repeat prescription unless there's a need for a consultation, and hopefully. I'm very hopeful that the primary care reform agenda will get a kickstart. I'm having a chat to Steve Hambleton and Wally and others later this week because that's a big aim of Minister Hunt and mine, is to make sure that we properly support primary care, make sure it's an even more attractive specialty for our medical graduates, and that we reverse that balance where too many people are going off into non-GP specialist training in areas where there's oversupply at the moment, and we need to make sure that we restore the primacy or preserve the primacy of general practice.
If you look back, say, over the last 6 months, what are the things that you're most proud of?
I think I probably had an individual leadership role in the border measures. Pete's been talked about widely in the media that Saturday morning when I phoned Minister Hunt and we spoke to the Prime Minister and I said we need to close the borders to China. That was very hard. That was not international dogma. The UK and Canada said it was not a sensible thing. The WHO said it wasn't a sensible thing, but I think it was. And then later border closures, quarantine in hotels, all of those border measures I played a pretty lead role in, and they were done against a lot of international opposition, and I think I'm pretty proud of those. I think that the testing, that wasn't, I think we as a nation, it wasn't my leadership, but the Public Health Laboratory Network getting test up and going early and sourcing lots of testing kits, that meant that we didn't have what those countries that had big outbreaks, they missed those early cases in February. We got on top of them, we found them, we isolated them. And I suppose the other thing that I'm proudest of is the way HPPC has come together. I think my chairmanship has been part of that. And then how I'm really proud of the fact that our governments, federal and state, have collectively listened to the medical advice. So we've been able to sell a message to them, even when sometimes the message we sold was pretty unattractive to them politically. They have accepted that mantra along the roads. So yes, and I think sometimes on the way out, as relaxing the restrictions, again, some jurisdictions are much more frightened than others, and again, trying to get that consensus view has been something that I'm proud of.
What would you have done differently? Lots
of media have asked me this, and it's hard. I mean, I suppose one thing I might have done way after the Diamond Princess cruise ship, I came out and made a lot of warning statements about cruise ships, and perhaps we should have made even stronger warning statements about cruise ships. I don't think we quite realise just how much of a viral incubator for this virus they are. So I think cruise ships are something that perhaps in another pandemic, we might have made stronger warnings about. People say we should have done hotel quarantine earlier or closed the borders earlier. I don't know if that's true, because most of closing the borders, people think, that stopped things. It didn't stop Australian citizens and permanent residents coming back, and they're the major source of infection. And as soon as that volume of returning travellers was was small enough to be able to fit into hotels, we did do the hotel quarantine. So I don't think we could have done that any better. Look, I don't at this stage. I think probably be able to look back with a bit more of a critical eye in a few months' time. But I'm actually pretty comfortable with how we've responded at the moment. And I think most of my colleagues are.
So what were the moments that sort of challenged you personally during this?
I think I remember a few. Well, obviously, ringing the Prime Minister and then a series of processes happened that we shut the borders at the end of the day. That was a momentous decision. Putting every Australian citizen in a hotel for 2 weeks with the mental health impacts of that worried me, but it was the right thing to do publicly. And one moment that really struck me is I think after we introduced the severe end of physical distancing, where we closed down, seated restaurants and a lot of gyms and cinemas and a whole lot of entertainment and hospitality. I remember driving to work in Canberra a few days later, or the Monday afterwards, and seeing a Centrelink queue that probably had a couple of hundred people in it. And that would really struck me, that the implications on the lives of ordinary Australians that our decisions had. And that's why we were very determined to only go as far as hard as we thought necessary, and not as hard as, say, New Zealand did. But even so, we put a lot of people out of work, and I'm very pleased that the government introduced the JobKeeper, because that's kept people going. But there is still, the lives of many people have been affected by what we've done to protect the health of the community, and all of us in the health sector are aware of that.
So as doctors, of course, we've got a really good understanding of the stress of being on call and doing long hours, but you've sort of been on call for 6 months. How have you managed with that constant stress?
Yeah, it was tricky for the first few months. I mean, literally, as I said, I might have done 3 breakfast TV programs, a cabinet meeting, a press conference, evening TV. Probably was working I'd be up at 6:30 checking numbers and talking to ministers, and probably crashing at 11:30 with the occasional middle of the night phone call from another country, which I tried to avoid. I think early on that was really tough, particularly when the case numbers were growing. I'm not a naturally very stressed person, and I've always taken the view that if you're doing what you, to the best of your ability, what you can do, and you're transparent and honest, and you ask for help and you recognise your limitations, then the pace was so great that I couldn't stop and reflect on decisions.
So what other strategies helped you to actually manage that constant stress?
It's been one of the things I like doing normally is going to the gym, but I shut them down, so that was a bit of a problem. So I've been trying on the weekends, at least, trying to go for some walks, some bush walks, just not very long ones, but trying to sort of tune out a bit. I try to read occasional novels for a little bit to try and unwind. But I probably haven't been all that successful at that. Fortunately, I sleep well, and I think that's really important. So I've been trying to get sort of, at least 7 hours sleep a night for most nights, and that's been quite important.
Again, looking back, how do you think this experience has changed you as a doctor?
Yeah, I think it's given me obviously a huge breadth of knowledge about public health and communicable diseases. It's shown me how in an environment of great uncertainty, where there isn't a rule book or any scripted pathway, the value of just getting a diversity of opinions and seeking advice and being really honest about what you don't know. And I think that's been, I used to say the only cardinal sin of a medical practitioner is to not recognise when you're out of your depth. When you need help, there's nothing to be ashamed about as a doctor, and there have been lots of occasions in this pandemic where I had no idea, and brought good people around me, sought advice, and just about every doctor I know will take my phone call and give me advice. And I've rung lots of random people, what's your advice on this drug, or what's your advice on this? And there's lots of expertise. No one doctor can know everything. And I think just being humble enough to recognise that and take the collective advice of others is probably the key message for me.
So, and again, I guess the same question, a slightly different slant, is how do you think the experience has changed you as a person?
Well, it's some interesting things. One of the weird ones is that when I go to the supermarket, I wear a cap and sunglasses because I've become recognised, which I find quite uncomfortable. In a positive way, people are not negative, but I like being incognito when I'm shopping or walking or at the gym. It's hard to wear sunglasses at the gym, so that's changed me. I think I've got a deeper understanding of the way governments work and what drives, because I've been dealing, I've been in the National Cabinet, so it's me and the premiers and the Prime Minister, and they're just and interacting at that senior level of government in a very active way for really the last few months. So, and it's interesting, again, really rewarding to see how they've all come together too. So I've got a deeper understanding of what drives government, and I'm also I'm also aware of how vulnerable a lot of our medical colleagues are, how frightened many of them have been, and how we need to understand that.
Look, and then you talk about having a little bit of a break and then starting in your new role as the Secretary of the Department of Health, which has been postponed, of course, for 6 months. What are you hoping to achieve in that role?
Health system reform. I came to the department not to really run a public health crisis, so I broadened the Chief Medical Officer role, used just to do mainly public health, but in the last few years, I've broadened. I've been running the National Medical Workforce Strategy. I'm very, very involved in medical research, in the primary care strategy, in the rural workforce strategy. So I want to do a lot of work in system reform. So finish off the medical workforce strategy, do all that stuff we have to do to make primary care stronger. I want general practice to be, the training position of choice for our graduates, because and I don't want to be turning out consulting specialists in specialties where there's oversupply and we don't need them. I'd like to look at our, the sustainability of our health system is a real issue. We've got to make it sustainable. Getting back to things like even out-of-pocket costs, which were one of the things that I was driving before. A lot of those things are really important. Making sure that we continue to do the MBS review and PBS reform and all of those things. Mental health is, there's still so much to be done in mental health, and making sure that the Commonwealth's investments, are not competing with the state's investments, that we work together in a coordinated mental health system. So I just love that reform agenda, and that's what I want to. That's why, the PM and the Minister are very keen for me to move into this role. I've got very capable hands in Paul to run, the public health response now, and all the other people helping us. So that's the aim.
Just a couple of final questions. One of them that's been very interesting to me has been the public health communication. And I was just wondering what you've learned about public health communication during this period of the pandemic.
Yeah, I think one of the perhaps criticisms is that we were a bit slow to get that going. I think we've now got a really slick comms team, and there's lots of messages out there. It was really hard early on because the message kept changing. I remember writing to every GP, but the letter would be different week by week, and then we had to change our medium. So we had the health website was what we saw as the initial major communication pathway, but that was clearly inadequate, and we had to get into social media. You've got to have simple messages. And you've got to use multiple media. So I think we learned a lot about public health communications, and I think hopefully we're doing it pretty well now, but it was a bit patchy to start with.
You spoke previously about the team that you've built up of your deputies, and I was just wondering what advice you might give to doctors about teamwork and leadership, particularly in a sort of a crisis setting such as this.
Yeah, the most important thing is to leave your ego at home and, really just open your mind to the ideas that are around you and recognise that nobody is a full-blown expert in this space. So I think just being humble and open to having other advice and I've learned so much from my deputy team. I've learned some of the basics of public health really from a lot of them. So I think that's the most important thing is all of my, even when I was a hospital CEO, I think we had a pretty successful 11 years, but I would attribute that to getting a really good team around you and trusting them and giving them, a lot of the stuff in my deputies, they've just run things on their own. I haven't double checked and I haven't wanted to sign off on everything and have everything accountable to me. You can't do that. You've got to trust your team.
Yeah, no, that's very important. Building that team and trusting them, I think that's very important. I think that's a good note on which to end it. So, Brendan, look, I just want to say that this has been truly a fascinating experience, and listening to you, I want to thank you, really, for the work that you've done to protect both the community and us healthcare workers. I've learned a lot from you and wish you all the best for your future career.
Thank you very much, Penny. It's been a great pleasure.